Good afternoon. My name is Alison Bollinger. I'm a registered respiratory therapist and have been for 8 years. I've worked coast to coast as a traveler. I worked on the East Coast and the West Coast. I've worked in 100-bed hospitals and up to 1,000-plus bed hospitals. And I have come to one conclusion, and that is nobody knows what I do. Great example of this. Last weekend I went out swing dancing with my husband. I was on the dance floor making small talk with a stranger. He asked me what I did. I replied with respiratory therapy, and he looked at me and said, "What on earth is that? Is that like physical therapy? Or is it kind of like a nurse?" Neither. Respiratory therapy is a very specialized, highly focused part of healthcare, and it's what I happen to love. So if you'll stick with me for the next 20 minutes, I will tell you all about it. We are, firstly, not nurses, but we are highly trained and highly focused healthcare providers specializing in lung care. All of our training goes into how the lungs relate to the rest of the body, how the lungs relate to your quality of life, how breathing affects everything that you do. And it's our job as your respiratory therapist to help you breathe the best that you can. We provide patient assessment skills. We provide breathing medications. We encourage breathing exercises after various types of surgeries, whether it's open heart surgery, any type of belly surgeries. We will be working with those patients just to help them take deep breaths and strengthen their lungs back up after being under anesthesia for so many hours. We are responsible for responding to any type of emergency within the hospital, whether that is a trauma patient coming into the emergency room, a code blue happening on the floors, or rapid response in the outpatient cancer center. Whatever it is, we are responding as a respiratory therapist, and we are responsible to maintain the patient's airway. Sometimes that does involve having to place an artificial airway or a breathing tube in the patient to make sure that they keep breathing and breathe for them manually with a resuscitator bag. Not all the times do we have to do that, but pretty frequently. It's a good part of what we do. And it's also a fun adrenaline rush. Hope no one's offended by that comment. If you are, then respiratory therapy is not for you, because we're a bit of a snarky group of people as well. We also work with patients who, just for whatever reason, their disease nature makes it hard for them to breathe. Cancer patients, patients who are born with cystic fibrosis, which is a very debilitating disease where your lungs produce massive amounts of mucus and your body doesn't produce the enzyme to break it down. You and I produce about 1 liter of mucus every day. Our enzymes help break it down. It lines our lungs, helps keep them open, and some of it we subconsciously cough up and swallow, and it also lines the rest of our stomach along with the mucus cells in our stomach. Cystic fibrosis patients lack that enzyme to break down the mucus in their lungs, and so it builds up and leads to frequent infections and frequent hospitalizations. So we see a lot of cystic fibrosis patients, and just work with them with different modalities to help break that mucus up so they can cough it out. We use equipment called the chest vest or TheraVest, Smart Vest. I'm sure there's probably a few other brand names I'm missing right now, but basically what it does is it wraps around their body and up over their shoulders, and it shakes and blows up with air and vibrates and helps shake the mucus loose so they can cough it up. We also have devices that you can blow into that will do the same thing internally. Some that are powered by air and some that are just powered by the patient's ability to breathe into it. We also work, like I mentioned earlier, with artificial airways. So any patient who comes out of surgery with a breathing tube or has a breathing tube placed because their medical condition is deteriorating and they can no longer breathe on their own, all of those patients are placed on a breathing machine or a ventilator. As respiratory therapists, it is our job, our primary job, is to maintain that ventilator. We're the ones making suggestions for changes. Depending on what hospital you work at, you might be the one changing everything. with protocols and working under communication with the doctors and the nurses to set the machine most appropriate for that patient. No two patients' lungs are alike, and so very often our settings will be vastly different from one room to the next, even though the patient might have the same disease process. So there is a lot of critical thinking, there's a lot of assessment skill that is involved with respiratory therapy. You need to be able to know how to read a chest x-ray, how to analyze an arterial blood gas reading, which we also draw those as well. The difference between an arterial blood gas and the venous blood work that most people have drawn is that the artery has the oxygenated blood already in it, and it hasn't absorbed all the carbon dioxide as the waste gas that your body produces, because the arteries carry blood from your heart to the rest of your body, and then the veins carry it all back. So when we draw out of the artery, we can assess, okay, what is the oxygen that is coming out of the heart, because that's coming straight from the lungs. Are we doing a good enough job? Do we need to change some of our settings here to better benefit the patient? Involved with that, we also get the amazing privilege of weaning patients off of the ventilator. Surgical patients are typically weaned off very quickly, but some of your patients that just stopped breathing due to their disease process or for a random reason, they can be a very, very slow wean, and it takes a lot of time to get them off the ventilator. But when you're able to remove that breathing tube and they can talk and say thank you and they're breathing on their own again, that is probably one of the most rewarding things about being a respiratory therapist, is knowing, okay, I've worked with this patient over the course of the last week. The patient has improved, they've gotten better. I can take them off the breathing machine. They're breathing good on their own. This is a good case. This is what it's all about. Unfortunately, part of our job is also removing the breathing machine when the patient is no longer going to get better. And you have to remove the breathing machine and just allow natural death, because that's what is best for the patient and it's what the patient wants. So that is part of respiratory therapy, which I did not know when I became a respiratory therapist. I did not know that that would be in my job description, but it is, and it's okay. It's okay to do that. On a more positive note, some of the fun things that we do are working with asthmatic children, and a lot of us end up working with ventilator camps with children who are on breathing machines all the time. Most of these children have been born with some type of disorder that prevents them from being able to breathe on their own or from being able to maintain their windpipe. For whatever reason, their windpipe will close, or it was malshapen in utero, and that's just the way that it is. They have to be on a machine to breathe. And so doctors will cut a hole in their neck and put a small tube into their neck so that we can hook them up to the breathing machine, and they can be awake and they can walk and they can even talk and run around carrying their breathing machine with them. And that is quite fun when you can play with the kids and see that the therapies and the interventions that you're doing are giving them a better quality of life than they would have had any other way. And that's actually one of the main purposes of respiratory therapy, is to help our patients breathe better so that they can enjoy life more. That's our bottom line. Most of our patients, our cystic fibrosis patients, the ones I endearingly call my old smokers with emphysema to the nth degree, asthmatic patients, a lot of these patients, they're never going to get better. Some asthmatics will grow out of their disease, but the others won't. It's only going to get worse as time goes on. But it's our job to educate them the best that we can on how to deal with their disease process, and it's our job to give the best recommendations that we can so that they can live a higher quality of life. We work in hospitals, we work in emergency rooms, we work in outpatient rehabs, we work in doctors' offices, doing all kinds of lung testing and patient education. We work in sleep labs. We do a lot of sleep testing with obstructive sleep apnea, which has recently become a very common term in our society and culture. We work with home care companies, helping patients, educating patients about their sleep apnea, educating parents about their children who have to come home with a breathing machine or a trach in their neck, or even if they just need a nebulizer machine at home for an asthmatic child. All of that education comes from a respiratory therapist. We also work, like I said, with all patient populations, and on any given day, I can seriously work with a premature child all the way up to the geriatric patient who is about as old as dirt. And I love the flexibility that my job offers me with that. It's different every day. You never know what you're going to get into. So, if any of that sounds interesting to you, you'd want to check out some respiratory therapy schools. There are 2 levels of accreditation. You can become a certified respiratory therapist, which takes 2 years, or you can become a registered respiratory therapist, which takes 3 to 4 years. Now, most community colleges that offer a 3-year respiratory therapy program for the registered respiratory therapy have gone now to doing 3 semester years, so 6 semesters in 2 physical years. And that was the kind of program that I went through. We went straight through the summer, year round, and really hammered out 6 semesters worth of credit hours in 2 years. If you go on for your 4 years and obtain your bachelor's degree, that does open you up more to get into the fields of research and management. Especially if you have your bachelor's in, say, biology or any type of healthcare administration, you really can open up some different avenues that other respiratory therapists wouldn't necessarily have a direct connection to. I do also have a friend who has her bachelor's in kinesiology and then went on to have an emphasis in respiratory therapy. And those types of degrees are very high valued for pulmonary rehab on an outpatient basis. We'll have patients come into the hospital gym and work with them on how to breathe through exercise to strengthen their lungs so that they can breathe better and be able to play with their children in the backyard or go for a walk with their spouse or just enjoy life. Like I said, a huge part of what we do is just being that advocate for the patient to help them enjoy life to the fullest that they can. So, if you're interested in some schools, there is a fantastic website on our National Accrediting Body's website, which is www.aarc.org. And you can find all kinds of school listings in your area, online programs, things like that. Part of our training also is doing clinicals, where we are matched up in the hospitals, either with an instructor from our school or with a volunteer therapist in the hospital itself, who takes us around with them on a day-to-day basis and teaches us more the hands-on type things. The biggest asset that we are to the nursing and doctor-physician teams is that we have so much experience in listening to patients' lungs and doing patient assessments in a very short amount of time. Because we listen to so many patients every day, our lung sound assessment experience increases tenfold compared to other healthcare providers. Just because repetition teaches. And it's like, oh, I've heard this noise before. Oh, this patient doesn't look good. I know what's going to happen next. And you gain that experience very rapidly working in respiratory therapy. I forgot what I was going to say next. But anyway. Oh, clinicals. So, part of your clinical training, you can expect to go through the day-to-day motions of a respiratory therapist. For example, when I get into work tonight at 7 p.m., I'm going to clock in, set my coffee down, put my stethoscope on, and be handed about a stack, probably about that thick, of treatment cards or patient assessment cards. And I will be given a verbal report about these patients. I will be told what their breath sounds are, what their chest x-ray was, what the plan of care is for the next 12 to 24 hours, I should say. Any snafus that the patient has had, any setbacks that they've had over the last 12 hours, or any type of interesting family dynamics that I need to be aware of before I go into the room, because in today's society we do have those. The next thing that I will do is check the computer to see if there are any new orders. Almost all hospitals are using computer charting now, so that's what we do next. Once we write down any new orders, we will go out and we will start our rounds. Typically, respiratory therapy does not stay outside of one patient's room for the entire shift. Nurses are assigned to a block of rooms and stay within that block of rooms for their shift. Respiratory will be assigned an entire ICU, or for one or two therapists, depending on the size of the ICU. Will be assigned multiple floors for one therapist, depending on how many treatments are on each floor, how many patients that we need to see. Typically a workload for floor patients, like the general medical surge floors. We're not talking patients who have artificial airways like breathing tubes or are needing higher levels of care. Just regular old patients that need a breathing treatment because they're asthmatic and they're having an attack. You can expect to see about 25 patients in 4 hours. So it can be pretty much, but it's also a lot of fun because you get to visit a ton of patients, you get to talk to a lot of people, and I like to talk, so it's a good job for me to have. We also, like I said, we provide that extra set of eyes and ears for the nurse. So a lot of times we'll then start our rounds. We'll start with patient in bed 1, work our way around, and somewhere around bed 7, bed 8, nurse from bed 18 will come over and go, "Hey, respiratory, I don't like the way this patient looks. Can you just come be a second set of eyes and look at this for me?" And you go, and you become that second set of eyes and ears for the nurse and just help her out. Then by the time 4 hours is up, all of the medications are due again, all the breathing machines need checked again, and you go back out and do it all again. And that's kind of how the workflow of respiratory therapy works. Like I said, it works slightly different than nursing. We're not quite as concentrated physically as they are in one location. On day shift, when there are physicians in-house and they are making rounds, we are expected to be part of physician rounds. We are expected to give an opinion about the patient's care and how their lungs are progressing, if they're getting better, if they're getting worse, and ways that we think we could improve and help them to do better, especially in the ICU. So that is what a typical work day and a typical clinical day would look like when you're doing your training. And like I said, our national body, the AARC, American Association for Respiratory Care, has a wonderful resource for different schools and what exactly we do, all written out for you. Hopefully you haven't been taking notes, because I tend to ramble and your notes would look a little bit chaotic. But that's pretty much what we do. We are the broad and narrow part of medicine. Broad in the sense that we see patients of all ranges, ages, and different types of lung disease, but narrow in that we really do focus on their pulmonary status. If there's something wrong with their big toe, unless it's affecting how they breathe, I'm not going to have an opinion about how to help that patient. But when it affects their breathing, because that big toe goes septic and is infected and the infection goes into their bloodstream and now they're struggling to breathe, at that point we are called and we are brought into the picture, and we can help the patient breathe better until they are able to take care of the infection. So that's respiratory in a nutshell. We help patients breathe better. So thank you very much for watching, and if you have any other questions, you can visit the website that I mentioned earlier, www.aarc.org/careers/what-is-an-rt. And that is our national board's definition of what exactly a respiratory therapist is, if you still have any questions after this presentation. Thank you again so much for watching, and have a good day.